Hello, everyone, and welcome to the March 2023 Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estebillo, Director of Training of the Tarjan Center, and it's my pleasure to be here with you today. Before we get started, a few reminders. We offer live Spanish interpretation, and you can click on the interpretation button that looks like a globe on the bottom of your Zoom toolbar and select Spanish for interpretation. Please also enter your questions for our speaker into the Q&A function throughout the talk, and we'll facilitate discussion at the end of the presentation. After today's lecture, please be sure to complete our evaluation survey. We love to hear from our audience what topics they're interested in and how we can better serve the needs of the Tarjan community. The link of the evaluation survey will be sent in the chat. And with that, I'll hand things over to Dr. Elizabeth Lageson, Director of the Tarjan Center.
Well, thank you, Jasper. Good morning, everyone. So I'm Liz Lageson. I'm the director of the UCLA Tarjan Center, which is, of course, is our University Center for Excellence in Developmental Disabilities. And on behalf of the Tarjan Center faculty and staff, along with our co-sponsors, which include the UCLA Center for Autism Research and Treatment, the UCLA Intellectual and Developmental Disabilities Research Center, and also the UCLA LEND program. It's my pleasure to welcome you to our distinguished lecture series, and also to welcome our distinguished speaker, Dr. Kyle Sterrett. By way of background, Dr. Sterrett is a postdoctoral scholar in the Lord Lab at the UCLA Tarjan Center and a clinical psychology trainee here at the Semmel Institute. Dr. Sterrett is a Bruin through and through. He received his bachelor's degree at UCLA studying psychology and history, received his Master of Arts in social research methodology also from UCLA, and his PhD in education from UCLA with an emphasis on developmental psychology under the mentorship of Dr. Connie Kazri. His research focuses on understanding the mechanisms of treatment response and how we measure progress for children with neurodevelopmental disorders enrolled in early intervention programs and classrooms. And in particular, he focuses on interventions developed for children with little to no spoken language. Clinically, Dr. Sterrett conducts autism and related psychiatric diagnostic assessments for individuals across the lifespan. He provides direct intervention as well as parent and professional training in the use of empirically supported early intervention strategies, including JASPER, which is an evidence-based naturalistic early intervention to teach communication and language, developed here at UCLA by our close colleagues, Dr. Connie Kazri and Amanda Goldsrud. On a personal note, I feel like I have also greatly benefited from Kyle's involvement in my own work at the UCLA Peers Clinic. Kyle, you have always been someone that we've been able to reach out to for help with our research. And, for that, I feel like you should be an honorary member of Peers. But either way, I'm grateful that you are officially a member of the Tarjan Center as a trainee under Dr. Kathy Lord, and we are very excited to hear more about your important work. So today, Dr. Sterrett will be talking about measuring treatment response with children with autism spectrum disorder at risk for long-term spoken language delays. We encourage you to ask questions throughout the lecture through the Q&A feature on the Zoom toolbar, and Dr. Jasper Estebillo, our Director of Training, will be moderating these questions at the end of the talk. So without further ado, please join me in giving a warm virtual welcome to Dr. Kyle Sterrett.
Thank you so much for the introduction, Dr. Lageson. Let me share my screen and we can get started. Okay, apologize a little bit. I'm getting over a cold now, so if I sound a little funny, I'm sorry, but I'm really excited to be here today. And like Dr. Lageson mentioned, I'm going to be talking about some of the challenges and some of the efforts to address those challenges and how we measure change in children who are in intervention and services that are targeting social communication skills. I don't have any disclosures or conflicts of interest to report. And I'm just going to start at the end. And there's three main takeaways I'd love for you to leave here with today. First is that measuring progress in children's social communication is really important. Second, there's lots of ways that we can measure progress in children's social communication goals who are in early interventions. And really, what are the benefits and drawbacks to some of the more common methods of doing that? And lastly, that there are a lot of really interesting active efforts to improve the way that we measure change in social communication and language over time. So those are the three things and kind of three takeaways I hope for you to leave with today. So when thinking about measuring social communication, I think it's important to take a step back first and look at the idea of early intervention for kids with autism. And I think overall what we know, there is a very wide range of early interventions and support services that are available for young children with autism. And these vary considerably across a lot of different dimensions. So in their intensities, so how many hours per week, how many days per week, what specifically they're targeting, in what contexts that they're delivered in. So are they in homes, in schools, in clinics, and also their philosophical approach. So are they more structured? Are they less structured? Are they parent-led or are they clinician-led? So there's a wide range of different services, interventions that are different on a lot of different dimensions. But I think overall, what we know about early interventions from the literature is that access to early intervention is really important, and access to early intervention leads to better outcomes for young children with autism. So regardless of the specific approach taken, on average, there are really positive effects on kids' developmental trajectories when they're given access to early intervention and high quality early intervention services. So what that leads into is, how do we know what works? How do we know that early interventions are helpful for young children? And in general, how we do this and how we consider interventions and services, whether that's in education, whether that's in psychology or medicine, to be evidence-based or empirically based, and know that it works, is basically when there's enough studies that have shown that it works. So we don't tend to rely on single studies. There isn't one study that shows that early interventions are effective, but we have lots of different studies and lots of different groups that have done this research. We kind of combine all of those smaller studies together into our evidence base. And there's lots of groups that do this kind of work, and they have different specific criteria in how they evaluate evidence, but in general, it's smaller studies getting combined together and looking on average how those are working. So just as an example of kind of this process and what this process looks like, this is a review that came out from one of the larger review databases called the Cochrane database. And they were interested in whether social skills groups for people from 6 to 21 who have autism spectrum disorder are effective. So that was the general question that they were interested at. And so they were evaluating the evidence base and the studies that have looked at those social skills groups. So this was in 2012, so it was a little far back, and there's a lot more studies now, including many that have come from UCLA, but their review even back in 2012 from the studies that have been conducted so far was that overall individuals who were receiving these social skills groups had better social skills, better friendships compared to those who were not receiving those social skills groups. So on average, this pooled effect, or the average effect of these social skills groups, was showing that this is an evidence-based practice. As just another example, and the question was whether communication interventions for minimally verbal children are effective. So this is things like PEC systems or speech generating devices or other augmentative communication systems like sign language. And overall, the conclusion from this particular study, which happened in 2018, was that there isn't enough evidence to say, basically, so far, that there haven't been enough of these high quality randomized trials to decide either way. And so basically their conclusion was we need to have more of these studies in order to evaluate whether this method is particularly effective. So I'm just giving these examples just as an illustration of how this process of deciding whether something is evidence-based kind of works in the research world, and how we make those decisions. In general, the number of these types of studies that are meta-analyses or reviews is increasing dramatically in recent years. So the graph on the left is just a quick search on PubMed, which is a research database about the number of meta-analyses that are related to autism and autism treatments or interventions and supports. over the last 40 years or so. And I think it's pretty clear that the number has increased pretty dramatically as of late. So there's about 200 to 250 studies published a year that are these kinds of reviews and meta-analyses just in autism alone. So there's a lot of them. And then on the right, this is just the any medical study on PubMed. So not just related to autism, but pharmaceutical studies and anything you can think of that's related to basically human medicine or psychology. And the number is even larger. So there's about 12,000 of these meta-analyses a year. And I think the point of this slide and what I'm just trying to show is that your understanding or your doctor's understanding or your therapist understanding of the evidence-based or what's empirically based is likely shaped by these kinds of studies, by these meta-analyses, either directly or indirectly. And so I think it's important to understand what they are, understand how we can make them better, and what are some of the drawbacks and limitations to how we currently use these types of meta-analyses and reviews. So going into one example in a little bit more depth that I'm just going to kind of carry through a lot of the rest of the talk. This particular study was a really important meta-analysis in autism that was recently published. And their whole goal was to look at early interventions and sort of update our evidence based on whether early interventions are helpful and improve kids' outcomes in autism research. So what they did is they looked at different types of targets. So on this right, things like adaptive skills, cognitive skills, language, and they grouped together the studies that had measured change in those particular targets. So that there's 21 studies that they found that had studied improvements in adaptive skills in young children. And there was 14 that looked at language specifically and whether kids' language improved over time. Their overall summary from this study was that most early interventions had small to medium effects, depending on the target specifically, but in general, and I think just an aside, small is not bad in this context, actually. Small changes can be really meaningful, and these were interpreted as being significant and clinically meaningful changes as well, even though that they were called small. So it's just kind of a way that we describe these kinds of studies, but it doesn't necessarily mean small isn't not helpful, which is interesting. So the goal of the next part of the talk is just going to explore some of the issues that are related to this method. And I'm going to use language and social communication as examples of some ways that we can think about how we interpret evidence and how we use evidence from these kinds of studies. So some of the kind of main issues related to meta-analyses and just autism research in general, I think are related to measurement issues. And that's what a lot of this talk is going to be about. So overall, some of the key issues related to measurement of outcomes are there's a lack of consensus about what measures we should be using to monitor progress over time. Only a small number of the measures that we use to track progress over time have evidence of validity and reliability. And an even smaller portion of those measures that are valid and reliable have been shown to be sensitive to change over time. So this evidence base and these studies of looking at these different outcomes, is the point is that they're oftentimes using measures that don't have a lot of evidence behind their ability to measure change, which is what they're supposed to be doing in these kinds of studies. So looking at two specific questions and two questions that sort of guided my own dissertation research in my own dissertation project. We were specifically interested in whether in these review studies, like meta-analyses, is it appropriate to combine different kinds of tests and measures together? So is it okay for us to collapse parent report measures of language with clinician-administered measures, with language samples, to make generalizations about language in general, or should we be viewing those different measures as measuring different things? And so that's sort of something that hadn't been explicitly evaluated. And so we're interested in delving into that a little bit more. And the second question is a little more specific, but whether different types of outcomes, so the way that you score even the same measure, does that affect how sensitive these measures are to change over time? So these are sort of the guiding questions for this project that I'm going to talk about. So for this, this project, we looked at basically a lot of really big databases, pulled together studies, and identified about 200 studies that were either early intervention trials, so they were testing an intervention, or were longitudinal studies that were tracking children's progress over time, and that included some kind of measure of social communication or language over time. So those are the kind of studies that we were interested in. And there were about 203 studies that were identified between like 1980 or so and 2021 was kind of the age range. So from those studies, the sample size was the median was about 26, and the children who were enrolled in these studies were about 4 years old on average at the start. And the median length was about 6 months of time. So these studies were about 6 months long. The kids were about 4 years old. And on average, they had about 25 kids in each study, but there was kind of a lot of variability in that. So from these 200 or so studies, went in and basically pulled out and looked at what specific measures that they used to measure progress in social communication and language over time. And after pulling those out, there ended up being about 120 unique measures that were pulled out from these 203 studies. So it's a lot of measures. So 120 different measures of social communication skills that were used across longitudinal studies in autism research. About half of those, about 55 of those measures, were used in only one study and not used again, or have only been used in a single study. So most of these aren't commonly used across multiple studies, I guess, is a takeaway of that. And I think what that really illustrates is that overall there's a lack of consensus on what measures to use to measure progress over time in social communication and in language. And also that there's just a lot of ways to measure similar constructs, even something like social communication and language. There's a lot of ways that we can potentially do that. So looking at that first question we were interested in, should we be combining these different measures together? So for example, should we be combining all measures that purport or say that they're measuring language? Should those can be combined together? And so in that prior meta-analysis that I talked about, they said there was about a difference of effect size difference of about 0.2 between treatment groups and control groups on language outcomes on average. So about 0.2 between treatments and controls in that original meta-analysis. In our data, when we looked at the specific measures rather than at this bigger construct at language, we actually saw quite a bit of variability in how specific measures track change over time and how much change over time specific measures are showing. So keeping in mind that average effect of about 0.2 for language, these were just 3 out of there's about 40 measures that we looked at, but these were some of the more interesting findings, or just to kind of summarize a general finding when looking at language. The first was we looked at the Vineland adaptive behavior scales, which is a measure of adaptive communication. So it asks, it's a parent interview that asks questions about both receptive and expressive language in young children. We saw that the children and students who were enrolled in behavioral interventions, so some kind of treatment at a university or provided by university clinicians, there was an effect size of about 0.4. And for treatment as usual, which was community-based interventions, the average effect was about 0.2. So that actually corresponds really nicely with what was found in that broader study of about a 0.2 difference between university-based interventions and treatment as usual when you were using the Vineland. But looking at different measures, so like the preschool language scales, which is a clinician-administered measure, there wasn't really much of a difference between those behavioral interventions and the treatment as usual interventions. And the effect was smaller, about 0.2 compared to 0.4 in the behavioral intervention group. And looking at a different measure, the RANEL, which is also a clinician-administered standardized assessment, there again wasn't a difference between the behavioral intervention and the treatment as usual group in terms of the how big the effect was or how much change over time that we were seeing. But the average effect was much larger. So about 0.5 on average compared to 0.2 on average if you were looking at the preschool language scales as a comparison. And I think one of the takeaways, there's a lot of variability in how measures of very similar constructs can change over time. And this is important to consider when a lot of our evidence-based is based off interpreting these kinds of effect sizes. So the second question that we're interested in is, are different types of outcomes more sensitive to change over time? So how you score measures, specifically standardized measures, does that affect the amount of change over time that we see? And the main takeaway here is that there is quite a big difference in how measures are scored and the average effect that we see over time. So using standard scores basically across any of these, and these are just illustrations, the Vineland again, and the Mullen, which is another standardized measure of a cognitive measure that measures expressive and receptive language. We saw that there is basically age equivalence. The effect size is twice as large in terms of change over time than standard scores. And so if we're basing our decisions about whether something is evidence-based based on the size of this effect, this could be a problem because it's really dependent on the measure and it's dependent on even how we score those measures. And this is the difference between like a small to medium effect and a large effect. And so whether we recommend a particular approach could be affected by how we're interpreting that. So just as a summary of this, the study and the main takeaways, I think it's mainly we need to be really thoughtful about the measures that we choose to track progress over time, both in research studies, but also in our clinical practices as well. And just being careful about how we're interpreting the summaries of evidence-based, just because depending on the measure that we use or the way that we score that measure, we could be interpreting results very, very differently. And the other takeaway is that choosing measures is quite complicated. So there really is not one right answer or one right approach to the type of measure we should use or what measure to use. And we need a lot more research and a lot more focus on this question about what are the best measures, what is the best way, best approach, or what's the best combination of approaches to be able to accurately measure progress over time in children who are in our research studies. So one solution that's being explored at the moment, and some development efforts are underway, is in standardized observations as one part of the solution to allowing for a more in-depth look at change in social communication skills. So next, I'm just going to talk about some of those current efforts to develop measures that were specifically designed to measure change over time in young children. So one of those ongoing efforts, actually here at UCLA in the Lord Lab, is the development of the Brief Observation of Social Communication Change, or the BOSC. So like I said, at UCLA, and also collaborators around the country and around the world are working on the development of this measure. And really the purpose and the goal before going into the details of what it looks like, is to address some of the current issues with those measures that we talked about in the previous study. So things like a lack of sensitivity to change over time. A lot of the measures that I was talking about previously weren't specifically designed to measure change over time. They were measured, or they were designed to measure very often stable constructs, or just to compare scores of children to the general population. So they weren't specifically designed for autism, and they weren't specifically designed to measure change over time. It also was designed with the idea that social behaviors are really subtle and difficult to measure. And so oftentimes those standardized measures, again, that I was talking about before, just aren't nuanced enough or specific enough to measure really complicated social behaviors. And the last issue is just addressing the lack of consensus on appropriateness of measures. So by building a larger collaborative group that's working on this measure development, you can start to generate enough data to evaluate how it's working. Is it valid? Is it actually measuring change over time? And so those are kind of the three main problems that this measure was supposed to address and is addressing. So there's been 2 validation studies that have come out so far. One for a version that was designed for minimally verbal children, or children who aren't speaking, and the other was for children who are using phrase speech but not yet fluent speech, or not for older individuals, so adolescents and adults. That version is also still undergoing development right now, but should be out relatively soon. So in terms of the details of what the BOSC looks like, it is a 12 to 16 minute videotaped play interaction with a standardized set of toys that can be administered by any adult, including a teacher, a parent, or a therapist. So I just kind of have the video over running to the left just so you can get a sense of what it looks like. And it kind of looks like play. So there are some basic rules and guidelines, but in general, it's supposed to be same set of toys, but playing naturally as you would with a child. There's some parts that include bubbles and different sets of toys, but basically it's play. Those video recordings are then later coded for very specific behaviors that are listed over to the right, and a lot of things that are related to autism symptomology. So how kids are gesturing and communicating with gestures, how are they using vocalizations, how are they responding to the social bids of adults, and also some repetitive behaviors and interests are also scored from those videos as well. So overall, from those specific behaviors, there's a social communication domain, an RRB domain that make up a total score. So, the next study that I'm going to talk about was applying this, the minimally verbal BOSC module to non-speaking school-age children with autism. So the original validation study was mainly included preschool-age children and toddlers. And so we were interested in seeing whether how the BOSC performed and whether it was sensitive to change over time in school-aged children who were receiving and enrolled in a randomized controlled trial. And one of the central questions that we were interested in, beyond whether it was sensitive to change over time, was whether the observational context, so whether it was whether the BOSC was administered by parents or by teachers, affected the change over time that we saw. So just jumping into a little bit of the details about the sample itself. So the mean age for the sample was about 6 years old. So about first grade, kindergarten. Their nonverbal IQ age equivalent was about 3 years old, 3.25 years. So these children were significantly developmentally delayed. And about 60% of the sample was using about 1 to 10 word roots or words in a 20-minute language sample. So using about 1 word every 2 minutes or so in a language sample setting. So they're not using verbal language very much and are developmentally delayed. So this sample was about 184 from the therapist-child interaction videos and 192 from the caregiver interaction videos. So the children in the study were assigned to, I guess before I go into this, children in the study were assigned to 1 of 2 treatments that have been showed effective in prior studies. The first was a Jasper intervention group. The other was a group that received discrete trial training, but all of them were receiving high quality behavioral interventions for about 16 weeks. So we'll start over to the left and just talk about some of the results. This first graph is of the caregiver-child interaction videos. And so these videos were coded at entry. So when they started the intervention, at 6 weeks later, and at the end of the intervention at 16 weeks. So overall, we saw that in the caregiver-child interaction videos, there was significant change over time from entry to 6 weeks. But that did not maintain to the end of treatment at 16 weeks. So saw less change over time in these caregiver-child interaction videos. And in the therapist-child interaction videos on the right, we saw that the average effect from entry to 6 weeks was significant, and that change over time from entry to 16 weeks was also significant. So these change over time maintained over the full course of the treatment. So I guess just to summarize, we saw more change in the therapist-child BOSCs than we did in the caregiver-child BOSCs. So I think just there's just a little bit more context on how these videos were collected. So the caregiver-child interactions were basically collected just at these time points, the entry, 6 weeks and 16 weeks. The therapist-child interaction videos were coded from the therapy sessions or the intervention sessions that were happening with the child. And so it's a slightly different context, not just in who was administering it, but also in what the context looked like in the administration. And so we also looked next at the differences between those 2 treatment groups and whether those differed in their amount of change over time. And overall, these p-values are representing whether there was a difference between the 2 treatment groups from entry to 6 weeks up here and entry to 16 weeks down here. So there's no difference between between the amount of change over time between the 2 groups in either the therapist-child interaction or the caregiver-child interaction. So both groups, there was change over time in the therapist interaction, and in neither group was there significant change over time in the caregiver-child interaction. And so next we were interested in really exploring and looking at whether there were systematic differences in the therapist-child interaction videos and the caregiver-child interaction videos at the item level at entry to the study. So basically comparing the scores of the therapist-child and caregiver-child interactions across each of the items. And what we found that there mostly were not different from each other, with a few exceptions. There was overall, children responded to the social bids of their parents at lower rates in the caregiver-child interaction compared to the therapist. And also in this engagement item, which is looking at how the adult and child are playing together and taking turns. Also saw that that was lower in the caregiver-child interaction. And there were a few of the items that were higher. There were more repetitive, restrictive behaviors in the caregiver-child interaction, higher activity level in the caregiver-child interaction compared to the therapist. And we also saw more aggressive behaviors in the caregiver-child interaction compared to the therapist-child interaction. So just kind of delving into seeing why those differences and what interactions look like with therapists as opposed to the caregivers. So just as a summary of this next story, this next study, context is a really important consideration. So there is differences in whether we are looking at parent-child interactions and therapist-child interactions, and we should take those differences into account when measuring treatment progress. We should really be considering where you expect change to happen, and make sure that you're measuring change in the context that you expect that change to happen, as well as in more generalized contexts as well. But overall, again, the kind of moral is to be deliberate about the choice of measure, and understanding that the change over time that we're seeing is affected by a lot of really complex factors, including the types of measures that you're choosing, the context that we're measuring children in, and all of those things can affect the results of the studies or how we're evaluating whether studies work or don't work. So just as a last step, one future direction that we're interested in taking in a project that we're currently working on is just talking about some future directions and ongoing projects related to individualized approach to understanding treatment response. So overall, how do we translate, and the questions I'm interested in answering, or how do we translate what we're learning from randomized controlled trials in these bigger studies and meta-analyses into everyday decision-making about interventions by parents and providers and doctors and teachers? How can we use all this evidence in a more systematic way, in an easier way, to inform our choices of treatments for young children who are in early interventions? So in a lot of these studies that we've looked at and that I've been talking about so far, we're really interested in and have been talking about, on average, whether children improve over time in their language, on average, whether there's a relationship between this intervention and treatment project. But there's sort of an underlying assumption when we're looking at these averages that just because there is an average benefit or an average effect of a particular intervention or approach or drug, for example, that that the relationship that we see on average holds for all children who are going to receive that intervention. But the families that we're working with, they're less interested in knowing what the average effect of an intervention is. It's more helpful to know what the likelihood that my child or my student will respond to this intervention and make progress. And so really interested in, are there measurement tools that we can develop to help facilitate that decision-making process at a more individual level? Just as an illustration of this idea, one framework that's been established in some medical fields, but also in other mental health related fields, is the idea of probability of intervention benefit. And just as an illustration of what this idea is, so for example, if I'm a clinician and a family comes to me for therapy, and I have two interventions that I can provide as a therapist, or two intervention approaches that I'm comfortable providing as a therapist, and that I know how to deliver for young children with autism. And after the assessments that I do with them, I know that this particular child has low levels of autism symptom severity, and also low language, so maybe they're using less than 10 spoken words. So if I know from my data that there's a 60% chance of making progress in intervention one for a child who has low autism symptom severity and low language, and a 25% chance of making progress in intervention two, it's pretty clear that I should suggest to this family or provide intervention one to this particular child. This decision, it seems clear, but we just don't have the data to make these kinds of decisions. And we don't have we just don't have enough data and have not tried to look at this sort of probability of intervention benefit framework. Even though it has been used in other populations and other clinical groups. So we're really interested in applying this framework and trying to develop information about whether there are specific characteristics that lead to a higher probability of response to different interventions. It also could be the case that if both intervention 1 and intervention 2 are both equally as likely to benefit a particular child, but maybe one is parent mediated and one is a therapist mediated, then I can start to target and start to recommend interventions that maybe fit better with a particular family unit or particular situation. So I think the kind of takeaway here is it's a really potentially helpful framework, and we just don't have much data about how to make these decisions as of yet. And so really interested in applying this approach and this probabilistic approach to early interventions for children with autism. And so one of the ongoing efforts that we have, and don't have data on this yet, but sort of have the outline. So we're interested in taking and have data from these 3 randomized controlled trials of early interventions. The first is the Early Start Denver model. The second was the Early Social Interaction Project. And the last was the Jasper intervention. And so these studies, or these 3 trials, have already been published, and they show that each of these 3 intervention approaches was effective in improving children's outcomes, but they all use different outcome metrics. So, for example, the ESDM study used standardized cognitive assessments. In the ESI and Jasper studies, looked at more observational-based measures to show effectiveness. So they're the same measure of progress isn't available for each of these 3 trials. So the original purpose of this, of pulling these data together, which was completed by Dr. Sophie Kim, was to apply the BOSC to each of these studies so that it can be evaluated sort of on a uniform scale, and so that they can all have the same outcome measure. And that study is still ongoing. We're interested in, as a future step of applying this probabilistic idea and probabilistic framework to these data, looking at predictors like age, IQ, and autism symptoms. So I'm really excited about this project. And ideally, the takeaway or the end message of this would be whether there's certain characteristics or certain children who have a higher probability of responding to specific intervention models. And that's not to say one model is better than the other, but they just vary in a lot of different ways in terms of their lengths, who is delivering these interventions, how intense they are, and how many hours per week. So being able to say that there is some guidance about which might be better for specific children could be really helpful. So keep an eye out for that project. So just to summarize and go back to the beginning again, the 3 main takeaways and what I hope you took away from today is measuring social communication in children with autism is really important and really hard to do. There's a lot of different ways that we can measure progress in children's social communication goals who are enrolled in early interventions. And there are also lots of ways that we can improve on the ways that we are currently measuring change over time in social communication and in language. So with that, just some acknowledgements of just all the families who participated in all these research that I talked about today, research assistants who helped with the project, and all of the collaborators both here at UCLA and many other places. And with that, I think we are ready for questions. Well, thank you for listening.
Thank you, Dr. Sterrett, for that wonderful presentation. I'll start us off with a couple thoughts, but before I jump in, just a reminder for our audience to type in your questions for Dr. Sterrett into the Q&A. In terms of additional information, so the slides and the recording of our talk for today will be available in just a couple weeks. So all of the registrants will get a notification once the recording and the slides are available. And all previous lectures are also available on our website if you're interested interested in reviewing those. And so please do type in your questions into the Q&A. But I think my main takeaways here are really just the importance in distinguishing the difference between a statistical significance, right, for all of us researchers and for parents and clinicians and the rest of us, just the difference between an individual difference, right, and measuring that response to intervention. I can say as a clinician and researcher myself that oftentimes I have conversations with parents about the importance in early intervention to pay attention to the response to treatment intervention and how we're, on a personal level measuring goals. Dr. Sterrett, any kinds of recommendations or thoughts on how to talk with families and individuals about how we on this side of things can measure treatment progress or the things that we should pay attention to in those early couple of years in interventions?
Yeah, I think it's a great question. I think it's really important I talked a lot about today about sort of standardized measures and standardized approaches to measuring things. And those tests take a long time and they shouldn't be done that often. And so I think when thinking about these types of measures that I talked about, like these interviews and standardized cognitive assessments, they're not done like every 3 months, they're not done every 2 months, they're not done frequently enough and shouldn't be done frequently enough for you to kind of really be looking at small changes or subtle changes over time. And I think as clinicians, we kind of do this naturally when we're talking with parents, and that we have other ways to more qualitatively measure progress, or we have specific treatment targets that we can track in a little bit more of a qualitative way. And so I think to supplement a lot of those qualitative ways that we talk about progress with families, these standardized measures just kind of another way or a supplement to looking at how generally in the big picture that kids are doing over time. And so I think it's really, in terms of the practical aspect for clinicians, it's not that we should be relying completely on standardized measures. It's just that a lot of times we do rely on these standardized measures when we're talking to families. And so just knowing what some of the limitations are to those measures and using those on top of the things that you would in normal clinical contexts too.
Absolutely. And I think that relates a lot to the different kinds of measures that we talked about with the standardized measures, like, for example, on the Vineland, that's adaptive communication. It's very different than when we're administering a Bailey and it's very specific kinds of presses. And so I was also really fascinated by the tail end of your conversation on the probabilistic models for intervention. And I think that's really the most exciting part with this type of work is, in the future, we'll be able to make those kinds of decisions and recommendations with our families and saying, based on these individual characteristics, this seems to be the most effective intervention for your family. For that line of research, I know that there's lots of exciting things there, but from your perspective, Dr. Sterrett, are there certain characteristics that you're mostly interested in or that you feel like, you want to leverage a lot of your research efforts toward?
Yeah, so I mean, some of the things that we're studying or looking at now are really from the standardized measures, but I don't know if it's what we have available in terms of the data, but I don't think it's necessarily the best route because a lot of those things, one thing, they're hard to administer, and other things, they do tend to be stable things over time for the most part. When you're thinking about cognitive ability or you're thinking about autism symptomology, they tend to be a little bit more stable. So I think looking at potential predictors or potential things that affect treatment response that are more malleable is something I'm really interested in. So are specific behaviors that we can work on or target ahead of time to help a child benefit from another intervention. So how can we use kind of interventions synergistically to maybe know that a particular intervention works better for kids who are better able to imitate. And so you can teach imitation ahead of time as a way to have them benefit more from that other more intense intervention. Just make things more efficient, make more kids benefit faster from those approaches that you're taking. So I hope to get away from the standardized measures as a predictors eventually into more things that are changeable, malleable, but that requires collecting some more data.
Right. Always comes back to the data.
Yeah.
And I think that that's a really good point, given, that we do work within the context of healthcare and healthcare systems and insurance, where, you might get authorized for a certain number of hours, but if in the future we can utilize all of this data and research to say, okay, this is going to be very effective, but also efficient, and obviously clinically meaningful for families. I think most of the conversations that I have in talking through treatment recommendations with families after that initial diagnosis, a lot of the feelings center around just that, I call it the sticker shock of the amount of hours that we recommend for interventions. And so I do think that, down the line, that's an important factor to consider when we're looking at what are some of the predictors of treatment response, and also how we can leverage a lot of this data for the goals that we have for each individual that's diagnosed.
Yeah, I think it just kind of also, it sort of leads away from there being one intervention or approach or set of approaches that are better or worse, and it's more like what's going to work for this child. And I think we know that there's not going to be one intervention that works for every child, and so better understanding of who's responding to what types of interventions, I think is really helpful in a practical way too.
I agree. I think that that's such an important part of the conversation. All right, I'm going to jump into some of these Q&A. There's some really great questions in here. One of the first ones that I see here is, my 4-year-old daughter has an IEP for ASD. I'm interested in outside treatment for her. I wanted to know how the Jasper treatment is implemented while she's attending school. So this is more of a kind of background, maybe practical applications on how somebody would do Jasper as well as a school-based intervention.
Yeah, that's a really great question. I think Jasper is considered a modular intervention, and so really should be implemented alongside of other services like school, community ABA services. And I think because it's a little bit lower and works at a lower intensity, so only a few hours a week compared to 20 or 30, it's really great in that kind of context, exactly. So it can be used after school when he's done, or in the morning before school, or in some cases for our research studies, even at schools too. So just doing pullouts from classrooms for an hour or so, so it's not disrupting the day so much. So I think intervention like Jasper is great exactly for that reason, in that it's modular, is not that many hours per week, but still can make a lot of change pretty fast. So I think that sounds like a great fit.
Great. Thank you, Dr. Sterrett. And I think maybe we can include some information on contact for how to get involved in Jasper programs at a later time. But thank you for that question. The next set of questions that I'm seeing here are really related to more toward kind of cultural diversity, individual diversity. So I'm seeing a couple of questions on whether there's a cultural aspect within the studies, and if these studies were pre-pandemic. But also another question about whether the standardized measures of outcomes that are better or more attuned for different groups of children, for example, biases, of course, that we know about Black or Latinx children. So maybe we'll start with that first one about cultural differences.
Yeah, so it's sort of the tough part about these sort of reviews and meta-analyses is that you can only do as much as the data has available. And a lot of the studies that we were pulling from a review were mostly white samples. And so being able to make those really important distinctions between how cultural factors or race and ethnicity might affect how different measures are performing is really, our ability to do that is kind of limited by the fact that most of our samples are white in the past 20 years or so. And I know it's getting better to some degree in terms of recruitment efforts to include more of those participants, but it's still a big problem that those groups are underrepresented. And because they are so underrepresented in a lot of those studies, it makes it tough to draw any kind of statistical conclusions about whether those measures are performing differently. But I think it's a really important subject, and not something we can keep ignoring.
Mm-hmm. Absolutely. I think that, there's just so many ongoing conversations, but it just highlights the importance of continuing to do more community partnered research, and to be in the community and to really listen to different types of families and value the diversity. I can't say from my side of things, in some previous work that I've done, that there are differences in cultural expectations, of course, with adaptive communication and adaptive skills. So that is the only bit of that I can build upon for that answer there. But as Dr. Sterrett had said, a lot of the standardized measures are very different, or they're clinician rated. So those are some of the only research differences that I'm aware of. In terms of the timeline of the studies that were conducted, Dr. Sterrett, can you talk a little bit more about for like the meta-analyses and some of these research, if they were pre-pandemic, or if we have any, post or during pandemic results?
Yeah, that's a great question. So all the studies that were talked about today were pre-pandemic, at least when the data was collected. So these were all interventions that were applied pre-pandemic. I can say that there is, I saw a study protocol for a meta-analysis that's specifically looking at telehealth parent-mediated interventions for early interventions for kids with autism, that's being worked on currently for one of those bigger databases. But that I'm not sure what the timeline of when that will be out, but there are going to be a flood of those reviews very soon, I'm sure. People looking at both telehealth questions and also post-pandemic intervention services too. So that's, I think I would say keep an eye out, and they'll probably be available soon. And there's some that are starting to trickle out.
Right. So stay tuned. Research kind of lags behind on of when the context happens, but data is very important. So we'll come back to that question in the future, hopefully. I'm also seeing another question about some of the literature review. So if there were some characteristics about parents. So one of the audience members is curious to know if there's the age group of the parents was also included. I think that might be really related to the differences between parent-child interaction and the therapist-child interactions.
We do have that data, and I don't have it currently in this slide. So that's a really great question. But I don't have it in that demographic table, and I don't remember off the top of my head. But I think that is an important factor, is thinking about the age of the parents too.
Absolutely, and I think there's some evidence that, of course, there's going to be differences in parenting practices based on the age of the parents, as well as cultural and individual factors. But we can always come back to that question in the future and take a look at some of that data. But thank you for that question from our audience member. All right, I think in terms of time, I'm just going to wrap this up with a couple or a last question for Dr. Sterrett in terms of important takeaways, or one of the biggest things that you think that the audience can use this information to apply to the work that we do, or the interactions that we have with the people that we work with.
Yeah, I think the main takeaway is really, I think, just being thoughtful and cognizant about why we're choosing certain measures. So I think it's really easy to kind of, at least I know from my own clinical experience, it's really easy to but it's really easy to use the measures that you're comfortable with, or use the measures that you were trained on. And so I think just being really careful about thinking about, why am I using this particular measure for this particular child, for this particular problem, is something that is hard to do, but I think worth the thought sometimes, and just branching out and seeing what are some other ways that I could potentially track progress in the patients that I'm seeing, or in the research studies that I'm seeing, and is the way that I'm doing potentially the best for this particular situation, whether that's in a clinical context of your patients, or as a researcher. I think it's just kind of important to stop and think about that too, because these measures are really different, even though they say the same thing, like they're measuring language or measuring communication, that can mean very different things. So just kind of being aware of that and conscious of that, I think, is my main takeaway.
Yeah, I think that's such a good reminder for those of us who work in this field, that we might have our standard battery of assessment tools that we're utilizing, but having that hand in hand with, okay, what are some of the other adaptations or factors that I need to make note of when I'm interpreting this information, as well as disseminating it to either a family or to the broader community based on the work that I'm doing. I think that's such a good reminder for those of us here.
Yeah.
Great. All right. So another reminder for our audience to please complete our evaluation survey for today's lecture. Give us some feedback on the content of today's talk, as well as suggestions for topics that you're interested in hearing for our future talks. I'm in the midst of planning some talks for next academic year, and I would love to hear from you in regard to what you are interested in. Thank you so much again for Dr. Kyle Sterrett for being here with us and presenting this wonderful information. I think all of us here are so grateful for the research that you do and the work that you presented today. And all of us are so excited for all of the future exciting things that you're going to be doing. So thank you so much, Dr. Sterrett, and thank you to our audience for being here today. We'll see you next month.
Thank you. Bye, everyone.